أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. This is the presentation for the final year students. If any postgraduate student can watch this, must watch this presentation, because it is the presentation which is important for the assessment of the pulmonary function. This is a clinical application of the pulmonary function test. We call it PFT, not LFT, lung function test, just to avoid the two terminologies interrelated. So I am Professor Syed Ali Haidar. I am the visiting professor of medicine in Sindh Medical University. I'll try to brief this as much as I can. A scenario: a 34-year-old lady presented with the shortness of his birth. The last 6 months, her X-ray showed bilateral hilar lymph adenopathy. Her pulmonary function tests were as follows. Major values: first of all, what are you measuring? These are the important parameters: major values, predicted values, and predicted how much it was predicted. So first of all, what are the parameters of it? That the forced vital capacity, it was 6.22 liter. Predicted values are the values which were calculated on the basis, just like INR. In that society, and in that geographical area, the mean of it, this is the mean. Most of the cases, most of the persons affected, FVC, calculated FVC, is called predicted value. It is 3.92 liter. So forced vital capacity 6.22. It was measured values by spirometry, and predicted value was 3.92. So forced vital capacity is fine. It is 74%. The forced expiratory volume in 1 second, which is spirometric again, it is 5.2 liter measured value by spirometer. The predicted value, which is already taken, for example in Karachi, is 4.2 liter. This is predicted value, should be 4.2. Again, it is more than that. It's 70% of the predicted. The forced expiratory volume in 1 second, the ratio of the forced vital capacity, if it should be 86%, it was 86%. The predicted value in most of the cases is 77%. Again, it is 97%. So it is definitely a good predictive value. It is on the higher side. Remember, this 86, predicted 77. But residual volume, you see, it is measured value is 0.9. It is reduced 1.2 liter to 0.9. It is 47%. It is reduced. So FVC is okay. FE1 rather is more. It's okay, fine. The ratio is also good, not bad. It is 77%. You have got 86%. Now interpret the pulmonary function test. Although the total lung capacity should be measured also. The parameters usually we measure are the forced vital capacity, the forced expiratory volume in 1 second, the forced expiratory volume in 1 second, ratio with the forced vital capacity, and residual volume RV, and we also measure in some cases the total lung capacity. That is volumetry that is called. If these are the essentialities of, you can say, of this pulmonary function test. Interpreted the pulmonary function test. I have already interpreted it. What is the most probable diagnosis? Because the lung residual volume is lower down, it is one of the restricted lung disease, or the other lung functions tests are normal or favorable in condition, or good, you can say. So it is the most probable diagnosis, the restricted type of the lung disease, because the residual volume is lower down. Further investigation should be done, X-ray test, and you do the sputum examination, you go for the HRCT, the important examination which you do in this case. And probably the lymph nodes, if you are suspecting the sarcoidosis, go for the direct evidence of the lung paratracheal lymph node biopsy. Now, information to gain from the pulmonary function test is that how much air is moving in and out, and how fast it's quick it is, and how stiff the lungs are wall, because the lungs and the chest wall, all system are working, and the reflexes from the diaphragm, which is originating, herring reflex, that is, all should be normal. And the diffusion characteristics of the membrane through which the gas moves determine a special test with the carbon monoxide test, which we actually is not done in our site. Usually, how the lungs respond to the chest physical therapy procedure. For example, if you give chest physical therapy and chest exercises, and afterwards you will do the PFT, what is the difference? Whether the bronchodilation, pharmacological or physiotherapy can benefit this patient. Indications are those present where you are not sure about whether it is obstructive nature of disease or the restricted nature of the disease. This is the most effective indication, or most commonly indicated indication. Especially helpful in the patient of 60 to 65 years of age, where there is actually, because of the age groups, now their ejection fraction is lower down, and they have got breathlessness on walking or simple walking, or you can say they are in the New York Heart Association criteria 1 or 2. You want to see this PFT, whether it is originating from lung or it is originating from the heart, or they have got the pulmonary disease actually or not. If they are obese, yes, the hyperventilation syndrome is another problem which is very, very not uncommon in this part of the world, but they are common in the Western affluent societies. History of smoking, etc., these are the indications. And anesthesia is given for a lengthy period of the time. The lengthy period of time will depress the respiratory center, it will reduce the respiratory functions. Or undergoing abdominal or thoracic operation, where again the same one, because the muscles, they are actually incised and the reflexes are originating. It is a discussion which I have done previously with the postgraduates, why it is affected. I am not doing it again, but they have got the influence on the respiratory functions. Now here you go with the pulmonary function test. What you do is the population studies, derived from it, from in geographical areas, Karachi, Hyderabad, etc. The percentage of the period normal is used to grade the severity of the disease. How much it is increased or decreased or equivalent of the predicted normal. So this is what you mean by the predicted. Just like PT-INR. The very good example is INR. The types of the PFT is spirometry and the lung volume. There are two types of the problems. One, you go for the spirometer, inhalation or exhalation. Lung volume are calculated by a meter which is connected with it, and a graph is made, and a loop is made with help, and it will indicate how much residual volume is there, how much is the total lung capacity, and others values. But remember, only parameters which we are using to evaluate are forced vital capacity, forced expiratory volume in 1 second, or forced expiratory volume in 1 second ratio to the forced vital capacity. Other than that, we do the other test like residual volume. It will determine the case. So this is the volume, this is the time. Inhalation, exhalation, inhalation, exhalation. A simple procedure, it will take half an hour. It can detect the forced expiratory volume in 1 second, forced vital capacity ratio will be calculated by a computer, and full expiratory flow rate can be done. It can be determined. Other parameters which are not written here can be all should be calculated. Equipment is simple one, which is available electronically now, is computerized. I don't want to discuss. This is how we do this. In a sitting position, the patient will inhale and exhale, inhale and exhale, inhale and exhale. This is a graph paper which is moving here. It's like electrocardiography. The variables impact on the PFT will be the age. You know that in the age it is directly proportional. It reduces lung capacity, elasticity, smaller lung volume, gender, volumes and capacities, etc. Gender, male has got more capacity, body height and size, and race, like blacks and Hispanics. Americans, they are different from the Caucasians. The terminologies and definitions, I already said the predicted normal. It is confusing type of terminology. Abnormal test often, not always, defined as less than 80%. In some situations it is 70%. Here it is written 80%. Or it is more than 120%. Most of the cases, but it may be 130% in other setups. The predicted value. So you will compare with the predicted value. Terminology, the tidal volume, this is the amount of the air inhaled or exhaled during the normal breathing. It can be calculated by the same thing, same meter. Minute volume can be, this is the total amount of the air which is exhaled per minute. Vital capacity, this is the total volume that air can be exhaled after inhaling as much as you can. Inhale, exhaled, not inhaled. Forced vital capacity means that after the patient has taken the deepest possible breath. Now this is the volume of the air which can be forcefully and maximally afterwards exhaled out from the lungs until no more than can be expired. Absolutely zero effort afterwards. Forced vital capacity. For expiratory volume in 1 second is important. This is the first part of the expiration. This is the volume of the air which can be forcefully exhaled from the lungs in the first second of a forced expiratory maneuver. It is measured in the liters. Now here is the FEV1, FEV1 minus FEV1%, FE3, FAC it is a ratio. Again with the FE3, usually we will not calculate it, but peak expiratory flow rate can be measured by the patient. The instrument is very simple. You can buy it from the shop. It costs about 1,000 to 1,500 rupees. It is a plastic object, and there is inside there is a bulb like things. It moves if you will forcefully inhaled or exhaled. Inspiration and ending of the maximal expiration. It will the peak expiratory flow rate. It is important those persons who have got the asthmatic attacks, or they are known asthmatics. After bronchodilation, how much the peak expiratory flow rate varies. This is important in cases of that asthmatic patients. The forced expiratory flow, it can also be calculated, although we are not doing normally. In R parameters, full expiratory flow 25%, and here there's the same one which I have said. Now these are the terminologies which we are using. Again, I will show you these things. The flow expiratory flow rate 50% or 25 to 70%, the maximum voluntary ventilation, having the patient breathe in out as rapidly as fully as possible in about 15 seconds. Now, it will indicate the capacity of the lungs to inhale or exhale. The interpretation is the general is that when the flow is reduced, it means that the lesion is obstructed. Expiratory flow, I mean, it is the expiratory flow. When the volume, if you are going volumetry, which is reduced, the lesion is restricted, which I have presented the case previously, and you can diagnose it on this base. The lesion is probably restrictive, in which case the volume is reduced. The obstructive airway flow, there is a lot of conditions in which the obstruction occurs. I don't want to mention it. Bronchial asthma, the extrinsic allergic alveolitis in initial stages, pulmonary eosinophilia, and the other autoimmune diseases, the chronic bronchitis and emphysema. These are the obstructed airflow pattern which you will see in this pulmonary function tests. The restricted flow are seen in the restriction occur in the parenchymal disease, interstitial lung diseases, lot of diseases, along with the diseases of the muscles are involved. The musculoskeletal system which are participating in the main muscle of the inspiration is diaphragm. The diaphragmatic diseases. So a lot of list is very, very long. Actually, it is written is only you can see sarcoidosis, tuberculosis, pneumonias, and restrictive lung disorders like scoliosis and kyphosis, ankylosing spondylitis, pleural effusion, pneumothorax, gross obesity, tumors, ascites, pain on inspiration, etc. Neuromuscular restrictive lung disorders like generalized weakness, malnutrition, paralysis of the diaphragm, and myasthenia gravis like muscular dystrophies, poliomyelitis, amyotrophic lateral sclerosis. And Guillain-Barré syndrome is also a problem in the pediatric world, specifically speaking. Again, the restricted flow. You have to do the pulmonary function test in this case to assess that the patient is out of danger. The criteria for the obstructed and the restricted lung disease is a general formula which is given that the forced vital capacity is reduced in obstructive, much reduced rather in obstructive, and it is minimal reduction is seen in restrictive diseases. If vital forced vital capacity increased after the pharmacological bronchodilation, then it is confirmed that it is obstruction. To differentiate between these two, you have to do the challenge of the bronchodilator. If vital capacity is the same after bronchodilator, it is restriction, the same. If there is no effect, it is restrictive. Okay, if you have the two parameters are used only. The slow vital capacity is performed by having the patient slowly and completely blow out of the air from their lungs. This eliminates the bronchoconstrictive effect of the rapid exhalation. The rapid exhalation will cause bronchoconstriction. Slow vital capacity, that is why in difficult cases we do the slow vital capacity. If you breathe in out and in out and in out, at one time the bronchospasms occurs. It is written in the Hutchinson clinical methods. Do not do it. सांस बाहर निकालो, सांस बाहर निकालो, सांस बाहर निकालो, सांस अंदर लो, बाहर निकालो. 13, 14 students are doing on one patient. After 8 patients, the patient will develop the bronchoconstrictive effect, and you will find bronchi in this patient even. The forced expiratory volume in 1 second, ratio with the word. This is very important. Normally it is 75% to 80% of the vital capacity, normal. Highly diagnostic obstructive lesion is because it's the first part of the expiration, which is definitely it is reduced, it should be reduced. How to tell if the patient is normal or has a mild disease or severe disease, depending upon it, how much the prediction is there. More is the abnormality, more are the severity of the disease which is written here. So it is a good test in the systemic way to interpretation. Steps are written here. I don't want to repeat it again. Indication should be there. Everything should be recorded, and then the spirometry and the volumetry will be done, and the interpretation afterwards. So volumetry, that is flow volume loops and helium dilution or carbon monoxide capacity or other gases can be used for the diffusing capacity. Usually we will not do this test. So lung volume definitions are the functional residual capacity. This is the amount of the air left in the lungs after exhaling normal. FRC, that is called. It is calculated by the volume metric of the instrument which will calculate it. Residual volume is important. This is the amount of the air left in the lungs after exhaling as much as you can. More is the residual volume, more are the nature in which the disease is more towards the restricted type of the lung disease. More is the residual volume, more are the chances of obstructive nature of the disease because it is actually entrapped air. The total lung capacity mean TLC. This is the total volume of the lungs when filled with as much as possible. In restricted lung disease, it should be reduced. But in the obstructive lung disease, it is increased. Air trapping is going on. These are the good parameters. This is a loop curve. It is calculated by the graph. It is not shown to the final year. So I will not do this in the detail. Now some cases should be described just to remember for the examination purposes concerned. The forced basal capacity 6 liters, measured value of the patient is 4 liters. It is reduced 67%. Reduced. Forced expiratory volume in 1 second, predicted value was 5 liters, reduced to 2 liters. 40% prediction now. Remaining is 40%. It is the conclusion. So it is reduced. And forced expiratory volume in 1 second with the forced vessel capacity ratio was 38%. The ratio. The ratio is 38%. The measured value is more, 50%, slightly more. It is 60%. Although it is less than 70%, but it is more than the predicted values. So it is a person which is obstructive type of a lung disease like COPD. The second case is, in this case, the predicted value is 5.68 liters. The measured value of the patient was 4.43 liters. It is 78% predicted. It is more than 70%. So it is satisfactory value, although the forced expiratory volume in 1 second is 4.90 liters. While the measured value you find in 1 second is 3.52 liters. It is 72%. It's slightly higher. Normally 70%, it's more than 72. Means slightly higher. Forced expiratory volume 1 second to the ratio with the forced vessel capacity is 84% predicted. Here measured value is 79%. And it is the predicted value which was predicted with the help of this was 94% they were expecting. Here it is 94% expectation. It means this ratio is increased rather. So this is the nature of the restricted lung disease, in which case the FVC may be normal, but this is reduced. This may be rather normal to increased. Another patient who had got the predicted values of 5.04 liters The major value is 5.98, means more 119%. 130% when 20% is normal in most of the cases. But it is in comparatively it is definitely a higher side. And the force expiratory volume in first 1 second was 4.11 liters, but 4.58 liters in major value, 111%. Yes, it's very good. The prediction is very good. FEV1, FEC ratio 82%, predicted major value 77%, very near to 94% prediction in this community, means that this is a healthy person, normal one, normal young person. Now again, another person who has got the vital capacity of 3.20 liters, the major value finding 2.48. Prediction is 77%. Percentage prediction, what is the normal? 70 to 120%. It is slightly, it is on the normal side. Although it is major value 2.48. It is satisfactory. FEV1 is 2.5 liters, major value is 2.19 liters. It is reduced, although the prediction was 87% in our community. But the ratio is 78% predicted values in that, and the major value is 88%. Our percentage prediction was 115%. It is rather very near to the normal. So this is the disease in which, for example, it is a mild type of a restriction lung disease, not the moderate one or a very severe restricted lung disease, but you have to compare with the residual volume, which is decreased in this disease, and the total lung capacity is definitely decreased in this condition. So you have to compare with the volumetric. You have to see the volumetric, parameters also. Another patient, predicted value 3.20 liters, major value 3.01 liters, 91% predicted. FEV1 is 2.5, major value 1.19 and 47 is reduced. The ratio is 78%. It is major value of the patient 59%. It is 50%. Both are reduced. If the residual volume was given or the total lung capacity was given, it is easy to diagnose. But for us, it is definitely a moderate obstructed nature of the disease, of course. And it is a moderate obstruction. And there are a lot of other examples, which I have not quoted because of lack of time. But what the students should understand, the parameters, the force vital capacity, the force expiratory volume in 1 second, that is important. The force vital capacity to the force expiratory volume 1 second ratio, the residual volume, or total lung capacity. 5 parameters if you have, you can easily differentially diagnose between the obstructive nature of the disease and the restrictive nature of the disease on the one hand, whether it is mild or moderate or severe depending upon the percentage which is predicted. If there is any question, you can put me on WhatsApp. Because of lack of time, I cannot answer it on this. But this is easy to understand. Inshallah, we will meet it again. I hope you have enjoyed it. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursaleen walhamdulillahi rabbil alameen.